Okay, Ahmed, let's go and start.
Okay, a 66-year-old former smoker presents with a 6.8 Crawford extent 3 thoracoabdominal aortic aneurysm. Which of the following is true regarding the indication of repair in his thoracoabdominal aortic aneurysm? Okay,
Before we start, usually thoracoabdominal aneurysm, what size we recommend repair?
6 centimeter
Yeah,
or
6 or
6.5 in some books.
yeah. Why some people 6.5 and 6? When do you go 6? When you go 6.5?
In connective tissue disease in general, you start in smaller sizes in the
No, but
background of
6 is
this.
not 6, not smaller. Always when you have like 6 and 6.5, that mean it's a risk patient. The patient, high risk patient, coronary artery disease, has a lot of heart problem, lung problem. You go with a higher number, 6.5. If patient has a good risk, low comorbidity, low mortality, go with a lower number. So usually when you see this range, this is what that mean. Low risk, you go with a lower number. If high risk, you go with a higher number. Okay.
Okay.
All right. So let's go with that. So what is the first thing?
Diagnosis of connective tissue disorder does not affect the size threshold for repair. No, you repair in smaller sizes in connective tissue diseases. It matters
Why we repair with smaller size?
because they tend to rupture at smaller sizes.
It's correct. That's very important. It's correct. Okay, next.
B, the presence of aortic dissection portends a higher risk of rupture at a smaller diameter. This is also true. This is true.
That's that's true. So if you have an acute stage, so what size usually we repair with aneurysm?
Above 4, the overall lumen.
4. Correct, but you have to be careful. What is 4? Like if patient has a dissection like 2 years ago and he came with a 4 centimeter dissection, do you repair it?
No, this is
So why you said 4?
this is in the subacute period, uh, complicated type of type B.
No, I'm saying it's uncomplicated. 4 uncomplicated type
Uncomplicated,
B. Type B. Do you repair it or not?
this is a bad feature of dissection.
Okay. Correct. So you repair it, right?
Yeah.
So why when it come after like 2 years you don't repair it with a 4?
Now it became chronic
صحيح. So
with a stiff septum.
صحيح. So become less. So 4 centimeter is only for acute dissection. Okay. So when we talk about acute dissection or subacute dissection, uncomplicated, then we go 4 centimeter. When patient come later on, couple of years after dissection, we don't go with this number anymore. We don't look at this risk factor like the tear size, the post-domain size. We don't do that anymore. All these numbers only in acute and subacute stage. When he come as a chronic, then we go like a normal aneurysm. But even though we have a threshold lower, we go with a 5. We don't go with a 6. So when you have a dissection, our threshold is 5 because they tend to rupture higher than the atherosclerotic disease, but not 4. So 4 for acute and subacute, 5 for chronic, and 6 for atherosclerotic disease without dissection. Okay?
Okay.
So this is the number you have to remember. Okay.
All right. C, risk of rupture of the infrarenal aortic segment is higher than that of the thoracic aortic component.
Right. What do you think? It's correct?
We repair
It's
the
not different.
abdominal part at a smaller size.
No. What I'm saying is that if you have a thoracoabdominal aneurysm, like thoracic and abdomen, it's a thoracoabdominal. So it has an abdominal and thoracic component, right? So are they
Yes,
asking which one has higher chance of rupture? Is the abdomen or the thoracic part of the
the thoracic
thoracoabdominal?
part.
No, it's no different. Okay,
No
so it's no
difference.
different.
Oh,
No, so there's no difference. It's not like one higher than one. So when you have thoracoabdominal, anyone could rupture. And both go with 6. Like if you have thoracoabdominal, we don't go with like 5.5 if the infrarenal 5.5. No, we still go with a 6 because we look at the total thoracoabdominal aneurysm. So when patient comes thoracoabdominal aneurysm, we look at 6 centimeter and the largest diameter. It doesn't matter in the thoracic or abdominal part. Okay.
Okay. What if we are not having thoracoabdominal? We have two, thoracic and abdominal, and both in the
No,
range of repair.
no. This is then you have then everyone. Then you go with each one its own criteria. So if they are separated, not thoracoabdominal, then you
مثلا
go 5.5 for the abdomen and 6 centimeter for the thoracic.
with the
If it's are
priority,
combined,
mm,
priority to the which one is larger because the risk of rupture is the same.
yes.
So which one is larger, you go with it, you know.
Okay.
Or sometimes you have to do them both at the same time. It depends. If you do an open or endovascular, you can do them both at the same time. Okay.
All right. Okay.
All right. Let's go
Smoking
to D.
cessation has been shown to decrease the risk of rupture and slow thoracic aortic aneurysm growth. This is known in the abdominal. It protects when you stop smoking. It prevents from growth, but in thoracic is not well known.
Right. So we know smoking increases the risk of rupture. Right. This is the only we talked about that last time. Smoking increases the risk of rupture and decrease the incidence of rupture for the abdomen, but not the thoracic aorta. I mean, it doesn't mean that thoracic. It may be, but we don't have a data. You see, now we are talking about data. It could be thoracic also decrease it, but we don't have a data. So we don't have a data. We cannot say it will decrease the risk of rupture. Okay.
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 E, there is a level A evidence regarding size threshold for thoracoabdominal aortic aneurysm. Well, I believe we don't. عشان كده في range 6 to 6.5.
Yeah, it's a consensus, right? We don't have a trial like an infrarenal abdominal aneurysm. We don't have really a trials where we compare risk of rupture. So it's kind of like of multiple single, centers, cohort study, meta-analysis, people experience, they all came with this number, but we don't have really level 1A evidence. It's kind of like an agreement more than level 1 evidence. All right, so any question about this one before we go? All right, let's go to the next question so we don't waste time. Who's that? Yahya, I want to take this one.
Okay, Dr. Samer.
Let's take this one.
Oh, sorry. 70 years old man present with chest and back pain. CT scan is shown the patient admitted in the ICU and managed medically with beta blocker to keep the systolic blood pressure 100 to 120. An indication for urgent thoracic endovascular aortic repair. As you see in the image, it is type B aortic dissection at level of subclavian.
Correct. Is any complicated? They said they didn't mention anything about complication, just chest pain and back pain, right?
Yes. Yes.
So this is uncomplicated kind of type B dissection. So indication for urgent thoracic endovascular when he developed symptoms, right? This is usually the urgent. Otherwise, this one should treat it medically, right? Uncomplicated type B dissection without the risk factor, we treat it medically. And this one, I don't see any risk factor. It looks like I don't see aneurysm. The entry tear looks like small, even though I don't have good data here. But doesn't look like an ugly dissection. So most of it is uncomplicated type B dissection, and especially now in acute stage. So I'm going to treat it medically, But indication for urgent thoracic endovascular if we develop any symptoms, right? So let's see what options they give us.
Okay.
Let's see here. Okay.
A CT scan that shows propagation of the dissection flap into left common iliac artery. No.
All right. So if that's stuck, no, because not a big deal. What's the problem? It can go to common iliac artery. It's not a problem.
If no,
unless if it's acute ischemia.
Yes.
See, did not mention as far as
yes, not to mention
right.
Dr. Samer.
Okay, because not mentioned, we have to presume that it's not there, correct?
Yes.
Okay, so if they said it was acute ischemia, yes. If propagation of the dissection flap to left common femoral artery or patient comes with acute leg ischemia, then yes, they have indication to go and proceed. But just the flap going to the common iliac artery, Without symptoms, still not indication for urgent. Okay.
Okay, Dr. Samer. We will manage him as medical.
Conservative.
Yeah, conservative.
Yes.
B, history of
Yeah,
non-connective tissue disease.
Right. Remember what they said here. Have to look at the question. They said urgent, right? You look at that, urgent. That means something had to do an emergency. So connective tissue disease, yes, you have high chance of complication, high chance of rupture, but doesn't mean that you have to do an emergency. So if patient comes with some same picture with a Marfan, it doesn't mean that you have to take it as emergency middle of the night. Yes, you may do it on lower, maybe like within 2 weeks, maybe you have lower threshold to do a TVAR, but it's not an emergency. You get the question, you have to be careful what the question is. The question telling you have this patient, what feature you need. If you see it, you have to take it as an emergency in the middle of the night. Okay. So extension to the left common iliac artery will not. Acute ischemia, yes. Non-connective tissue disorder is not an emergency, but possibly you need to have more aggressive later, or maybe you pray him earlier, but it's not an emergency. Correct?
Yes.
Okay, this next one.
C, oliguria that improve with volume resuscitation. No, that
Okay.
the kidney perfused well, only improved with volume resuscitation.
Okay. So if this is just oliguria without improvement of
D.
volume station, is indication?
If affected the renal,
in the exam.
the kidney.
Yeah.
Yeah.
You're in the exam, and they just give you the C, oliguria. That's all, and stop. Is an indication? Yes, it's indication because this is mean that dissection went to the kidney. So oliguria, you have to think first thing about dissection extend to the renal artery, and now the renal artery is thrombosed, or you have a dynamic, obstruction. So yes, oliguria is an indication to do an urgent interventions. But when he said improve to volume resuscitation, he wanted to tell you, look, it's not from dissection, it's from hypovolemia. Patient is under resuscitated. So this one, yes, I will not. But if he did not say this one, this sentence, oliguria, yes, is an indication for urgent intervention. Is it clear?
Clear, Dr. Samer.
No? Okay, let's go next one.
D, abdominal pain out of proportion to the exam. Yeah,
Okay.
this is a picture of bowel ischemia.
Correct. Last one.
Develop pleural effusion.
Is that an indication?
No.
No, because it's not the blood. If it's a blood, the pleural effusion, yes, ruptures. Okay, so you have, even when he said abdominal pain, if he didn't say out of proportion to the exam, you have to question that because it could be for something else. But when he wrote out of proportion to the exam, this is bowel ischemia, then you have to interfere. So again, anytime becomes symptomatic, like ischemia, bowel ischemia, kidney ischemia, liver shutdown, then you have to do an emergency intervention. Otherwise, you just continue conservative management. Is it clear?
Dr. Samer.
Question? Yes.
Yeah, clear.
Please.
What about high creatinine?
It's good. You see,
With
when you
type
have
B
these
or the
things,
classic?
this is a good question. At this time, you have to do more of this. This is an exam. So exam, you don't have time to invest. This is an exam, black and white. In real life, it's different. Patient come with oliguria, the first thing I'm going to do an ultrasound because how would I know it's a volume resuscitation, hypovolume, or dissection? So patient come with the oliguria, the first thing I'm going to do a CAT scan. Not CAT scan, an ultrasound, because oliguria, you don't damage the kidney. I'll do the ultrasound to look at the renal. If the renal artery is open, then it's not dissection. If he came with abdominal pain out of proportion to the exam, I will do a stat CAT scan. Remember, when patient with a bowel ischemia, even if the creatinine is high, you do a CAT scan with contrast because bowel ischemia is a deadly consequences. When patient comes with dissection of bowel ischemia, the majority they die. So don't worry about the kidney and damage the kidney. This is a life saving. So patient like with a renal like CK4 or 3 and came with abdominal pain out of proportion after dissection, get a stat CT scan with a contrast. You want to see how is the celiac to see if it need to be fixed or not. Okay, because sometimes it could be an emboli, it's not a dissection, you know. So you have to know what your pathology is so you can deal with it.
I have a question, Dr.
Okay.
Sam.
Yes, please.
In case of malperfusion, we are going to do emergency TBAR to close the intersite of dissection.
Correct.
For example, if he has pain out of proportion, are we going to evaluate the bowel, I mean surgically, or we should wait?
I mean, your voice not clear, Ahmed. What you're saying that patient came with a bowel ischemia, scan to dissection, and you do a TVAR, and then you're
Yeah.
asking, do you need to evaluate the bowel after you do a TVAR and reperfuse the bowel, correct?
Yes. At the same
Yeah.
time, or we should give time?
No, I mean, it depends how you feel about it, how much is lactic acid. If lactic acid is too high, you know, I mean, after you finish, you could do an angiogram and you see, if you see flow good, the bowel is very good, then you know you reperfuse the bowel, but the bowel maybe is already dead. And all this depend on your physical exam and on the lactic acid. The lactic acid is high, and if you see, they said abdominal pain out of proportion to the exam, because in bowel ischemia, you have severe abdominal pain, but you examine the abdomen is soft because it's still first stage. But when you have a bowel ischemia, like late stage, like gangrene bowel, then you have a tenderness and rigidity in the abdomen, then become different. Then you have to put a scope and look. So if the lactic acid is high and you examine the patient, he has a tenderness, a rebound tenderness and gardening, then yes, you have to look at the bowel. But if the abdomen is soft and you do the angiogram, and completion angiogram looks like normal, and lactic acid is not too high, just watch him and follow up with lactic acid. If you see lactic acid start going up, then yes, I'll go and put a scope and look at the bowel.
Thank you.
Okay. All right. Let's go to the next one. Farah, you want to take this question?
Yes, Dr. Sam. 65-year-old man with recent cocaine use present to the emergency department with chest and back pain and blood pressure of 230/110. He is found to have type B aortic dissection without any appropriate proximal landing zone in zone 2 or 3 for the thoracic endovascular aortic repair. There appears to be an evidence of rupture on the CT scan in the proximal descending thoracic aorta, just beyond the level of the left subclavian artery. Which of the following is true regarding open repair of the descending thoracic aorta for aortic dissection?
All right, let's say first. I mean, now the first line of repair of aortic dissection is endo or open?
It is endo.
Correct. It showed, all the data showed that the mortality is lower with endovascular than endo, صح? So now the first line of treatment for dissection is endo, not open. So when we do an open, when you have a rupture and you cannot control it, right?
Yes.
And this patient, they said zone 2 and 3, there's no landing zone, right?
Correct.
So they want then, and he's ruptured. It's not like you have a time to do fenestration and you have that time to do like, you know, modified physician fenestration or do a branched, you know. So this kind of patients, you have to take them right away to surgery because you have no landing zone for TIVAR. Okay, this is the only indication
Okay.
you do it in open. Otherwise, also we do a TIVAR, right?
Yes. For this patient, Dr. Samer, you can do TVAR and cover the subclavian.
But this is zone 2 and 3. Where is zone 2?
Zone 2 at the left carotid.
Correct. And they said in zone 2 is no, so you have to go to zone 1. He said he found to have a type 1 dissection without type 2
appropriate
حتى is
proximal.
no. So
Yeah.
zone 2 is not good. So you have to go to zone 1 or zone 0. So now you have like total branch, you know.
Yes.
You see? And usually in when zone 2, it's not, this is a rule, because distance between innominate artery and left common cord artery is very short. So when patient doesn't have a zone 2, usually will not have zone 1. It would be not, so you have to go to zone 0. Very bad to deploy the TIVA in zone 1 because you don't gain much. So if you don't have a good zone 2, that means most probably you need 2 centimeters. That means you're going to go to zone 0. That means you have the total D branch, you know. And this is a rupture, so you have to do it an open. I mean, you can still do, I mean, if you want, you can do the branching the neck, but this should be done as an open. And then the rupture in the descending thoracic aorta. You see what the problems? Because if you decide to do debranching, you got to go through medianostomy, whereas descending thoracic aorta need a thoracotomy. So it becomes so complicated to do debranching. You cannot open mediastinum and do debranching where the chest is full of blood and is bleeding. So the best way in this patient, just open the chest and try to fix it, you know, as much as you can. Most of this patient need a deep hypothermia because no place even to put a clamp because it's zone 2 and zone 1. So most kind of this patient have to put them on deep hypothermia, cardiac arrest, and to repair the arch with a descending thoracic aorta. It's like type 1 dissection. All right, let's see what they are saying here.
Resection and replacement of the aorta should be performed from the distal aortic arch to the level of the diaphragm, if possible. No.
Why not? No.
From the distal of the aortic
open.
arch. Yeah, you open,
Right.
but you need to apply your clamp proximal to the left carotid.
Look, Bara, indication for EVA different from open. Like when you have a juxtarenal aneurysm, you have to go 2 centimeters above. So you have to go and do fever cover like renal and celiac artery, correct?
Yes.
But when you do an open, you can put your clamp suprarenal and do an osmosis infrarenal. So
yes, you
open
can.
is different from endovascular. You see, it's different. So it doesn't mean that it doesn't have a landing zone in 2 and 3. That means if it's open, you have to go to zone 0. No, you can still go distal subclavian. It's just zone 2 and 3 is not good for endo, but doesn't mean that's not good for open, because open you take a big stitches and big pints, you know. So this is not an issue, you know. But the problem, he said, you have to go all the way to the diaphragm. You see, when we're dealing with the thoracic aorta, the rule is minimum is always advisable, because the more you take off the thoracic aorta, the higher chance of paraplegia, because you cut all intercostal, you see. So when you do thoracic aorta, we just repair the area where you have an aneurysm and repair. We don't go. If it's a distal thoracic aorta there, leave it alone. Don't put the graft there and don't take it more. So you don't have to go all the way to the diaphragm, because this increased chance of, you know, paraplegia, which is the worst outcome, especially patient hypotensive and ruptures, which increase chance of deep chance of paraplegia. So always you have to be very limited when you deal with the thoracic aorta. Just resect the part which is causing a problem and get out. All right, next one.
Okay, B, indication of open repair is limited to patient with impending or actual rupture with no proximal landing zone for TVAR. Yeah, this may be correct. Yes.
Yeah, that's what they said. Yeah, it's limited because always TVAR our fair choice. So open repair only when you have a rupture and don't have landing zone. Because if you have a rupture, a good landing zone, you do even TVAR. So the only indication really for open when you have rupture plus no landing zone. If you have no landing zone and no rupture, you can still do TIVA because you have time. You can do, you know, frustrated, you can do whatever. But rupture and no landing zone, this is the only indication you have to go with open.
Okay.
Okay.
C, double lumen endotracheal tube has no benefit compared to a single lumen endotracheal tube in the repair of descending thoracic aorta. No, that's wrong.
Why?
You need the double lumen if you do descending thoracic aorta open surgery. You need to deflate the left trunk.
Correct. Otherwise, it'll be in your way. Correct.
Yes.
Next.
The left radial arterial line is the preferred location for continuous intra-op blood pressure monitoring. No.
Why?
Because you are going to clamp or close the left radial, the left subclavian.
Right, because you can to clamp like suprarenal. Yes, you do an osmosis distal to subclavian, but you clamp will be between the left common carotid artery and left subclavian artery. So if you put arterial line, then you lose it.
Yes.
Like you see, like a exactly like juxtarenal. You clamp suprarenal and you do it infrarenal, and the same in this one. You clamp between the common carotid and subclavian,
Subclavian.
but you do anastomosis. Distal to subclavian. Okay.
Yes.
Next.
The classic incision for exposure of the entire descending thoracic aorta, starting from the distal aortic arch, begin at the 8th intercostal space at the posterolateral chest. It is actually should be at the 6th intercostal space posterolateral.
Why when you do that 8 intercostal space?
8 or 9 when you want to do thoracoabdominal repair, open thoracoabdominal.
Correct, when you go distal, because 8 is too low, so you cannot get to the aortic arch. For the aortic arch, you have to go to the 5th or 6th intercostal space. It's very important, you know. All right. Any question? All right, that's good. Let's go to the next one.
Yes, Dr. Samer, I have a question.
Yes, go ahead.
If you are going for emergency repair like this case, do you still have to do spinal drainage and all accessory?
Yes and no, you know. I mean, it depends how is the patient condition, if he's stable or not, you know. If you have a time, I prefer to do it. If you don't have time, I will do it right after. It depends, I mean, after the procedure, because this kind of procedure, patient will stay intubated for like at least for a day or two. So it's very hard for you to evaluate his neurological symptoms. You know? So it's better to do it before procedures. But if it's not, then I'll do it after the procedure. But also it depends how extensive you repair. If you're just going to repair like a small segment of thoracic aorta, no need for spinal drainage. But if you're going to end repairing like thoracic aorta all the way to the arch, to the diaphragm for some reason because of the aneurysm, then you have to do it. So it depends how is the condition. It's not like must, but it's better. Depend how extensive. But you're going to repair extensive links of thoracic, it's better to do it. But all studies showed that if you do it as prophylactic before or after the procedure is the same. So always you can do it after, but the patient has to be awake to evaluate him. But if it's not awake, and you resect like a long segment of thoracic aorta, and you didn't do it before procedures, I will do it after the procedure if patient is going to stay intubated. So the patient is going to be extubated and is awake, you examine him. If there's no neurological deficit, you don't need it. If he has neurological deficit, you go and put it right away. So you have to individualize your decision according to the patient.
Yes. And what do you do with the distal flap if you have an dissection extended to the iliac and you are planning to do only the thoracic?
Always you keep flow to the both flap. This is normal. Always you keep flow to both, the true and postomy. We don't close it, you know. So always when you open the aorta, you see the flap, you cut part of it. So the aorta and like for 1-2 centimeter become like one lumen, and you suture to that. So always will be a flow to the distal false and true lumen because some artery come from the false lumen. So you don't want to obligate the false lumen now. Always you can deal with that later on. So always when we do even the ascending aorta, arch, whatever dissection, always we suture to the adventitia and we give flow to the both true and false lumen distally.
Okay, Dr. Samer. Thank you.
And in dissection, always we do 2 layers because the artery is very thin. So we do 2 layers. Usually we do running layers with a plaget, like with a Teflon, like a piece of Teflon. And then better to do interrupted with a plaget also. So it's better also to do it with the 2 layers if you have a dissection because the aorta is very thin and 1 layer is not enough. So usually we used to do it. So what happened? You suture posterior wall with a plaget, and before you go to anterior wall, you go from inside, you put multiple interrupted sutures with a plaget. Even from inside, don't worry, aorta is big. It's not big deal. You can put plaget inside. And then after that, you do the anterior wall running, and after that, you put interrupted anterior wall. This is the way how we do it.
Okay. Do you need always bypass, or you can do it without bypass machine?
No, you don't need it. It depends how fast you are, you know, and it depends how is the patient. If it can take a long time, it's better to do a bypass. but we do it with the left heart machine, not with the ECMO. You can do it with the ECMO. You know what's the difference between ECMO and left heart machine? It's very important. You have to know that.
The cannulation place. The ECMO you
Yeah, but
can do in
what's the difference between ECMO and left heart machine? Like in my training, we never use an ECMO. We also use left heart machine. But these days, now people start using ECMO because it's easier. But what the concept is different. You know, if you got to go and talk to the cardiology, I need an ECMO or left heart machine. When you decide to go with this one, when you decide to go with this one.
I don't know.
Yeah, it's okay. Don't know. Anybody knows? Okay. You see, left heart machine is arterial to arterial. So we take it usually from the inferior pulmonary vein, because pulmonary vein has an arterial flow. So you put catheter in the inferior pulmonary vein, and the distal you put it in the femoral vein or distal aorta. So you don't need oxygenation because it's arterial to arterial circle. Whereas ECMO is arterial to venous. You take a venous, you oxygenate it, and send it back to the patient as a venous. So this is the difference between ECMO. So ECMO, you take a venous blood, oxygenate it, send it to the patient as arterial. Left heart is much simpler. You don't need oxygenator because you take an arterial from the proximal part and you refuse it distally. That's all. Okay.
Okay, thank you.
Yeah. Any question?
Dr. Samer, is there a rule for those devices C-tag with one branch, or laser fenestration or needle fenestration in complicated dissections?
Yes, there's a rule. If there's no rupture, then you can do whatever you want. If there's no rupture, you have a time to design the way you want. Yeah, you can one branch, fenestrated, complete endovascular. But when you have a rupture, you don't have time for that. Just have to go quick. But the elective case, yes, you can do whatever you want. You have a lot of options.
But theoretically speaking, fenestration faster than open thoracoabdominal, open thoracic repair.
For rupture?
Yeah, even in rupture, I think fenestration
not
is
really.
faster.
No, not really. No, not really at all. You
Mm.
see, what's the difference between infrarenal ruptures? Why we do for rupture infrarenal aorta, we do endovascular, whereas the rupture for thoracic, we do an open. Because in infrarenal, you can put an occlusion balloon suprarenal, no problems, until you get your device in, so you have a control. You see, in thoracic aorta, you don't have this legacy. You can put like occlusion balloon in the aortic arch. You get, ischemia to the brain, so you cannot do it. So you don't have this legacy to buy a time with the balloon, but you have infrarenal. So most thoracic aorta, if you don't have a good landing zone, you can do it quickly, then you have to do it an open. If you just rupture and contain rupture and you have good landing zone, of course, TEVAR is much better. But if you're talking about arch and fenestration and all things, you don't have time for that. I think you have to go with an open because you cannot put an occlusion balloon.
Okay.
Okay. All right. Let's go to the next one. Let's go back to you, Ahmed.
Okay.
ولا عبد الله معمل عبد الله لسه معمل نسينا عبد الله
دكتور
يلا ساكت عبد الله. Go ahead, take this.
سألتك سؤال دكتور.
بس صوتك ما كثير واضح. Go ahead.
Okay. A 75-year-old woman with 55 back-year history of smoking and active tobacco use presents to the emergency department with sudden abdominal pain radiated to the left flank. Her blood pressure is 100/50 and her heart rate is 85. A CT scan is obtained and she is noted to have ruptured 5.6 infrarenal abdominal aortic aneurysm. Which statement is true regarding the nature, history, and the presentation of ruptured abdominal aortic aneurysm?
Okay, I just want to know what the nature history of ruptures. Okay.
A triad of abdominal pain, a versatile abdominal mass, and hypotension occur in more than 80% of patients with the rupture AAA. No, this is too high percentage. It is maybe in 10%.
How much?
10, I think.
10 is very low now. No, you have to be fair. Maybe 40, 50%, something like that. But not 10, not 80. 80 is too high. You're right. But 10 is very low. So I think like 40, 50 is reasonable. Okay.
Okay. P, presentation with lowest systolic blood pressure less than 70 millimeter mercury should be maintained and is good prognostic indicator. We should keep the patient on progressive hypertension 70 to 80 systole.
So
I
what
want
about
to
this
see
one? They
that.
said less than 70.
No, not less than 70.
Yeah, this is hypotensive, right? And
Yes,
the data showed the patient comes with a hypotensive is a bad prognostic factors, right?
yes.
The patient comes to the ER with option aneurysm with a hypotensive, it's a bad sign of bad indicator for prognosis, correct? Well, you have to know, guys, for the exam, which trial talk about rupture aortic aneurysm endovascular? What's the name of the trial?
Improve.
Improve, yeah. So read that. So yeah, so read about it for the exam. I'm sure you're going to get a lot of question about it, you know. So always you have this is one of the good trial you have to read about. So patient less than 70 is hypotensive, and this is a bad sign. So it's not good. Yes, you need to kind of hypotensive, but not 70. Between 70, as you say, 70 to 90, but not less than 70. Okay.
Okay. C, age more than 80 years old with uncontained rupture of an infrarenal triple A is considered suitable for attempt repair, giving 100 mortality. No,
What is the mortality thing with this patient?
50%.
It's usually
50
how
around
much?
50. يعني.
50? 50?
Yeah,
No. Go higher. Go like 80, 90%. Very high.
that's
Because
not
regular
100.
patient with a rupture and you're not, but not 100, correct. Not 100, but it's high. It's more than 80% really. So it depends. In England, because they want to save some money, possibly they leave it alone. In the state, they will treat him. They don't care. But in England, these days now, patient move above 80 and renal aortic aneurysms and contain rupture, sometimes they said, oh, it's, risk of, survival. I mean, mortality is more than 80, 90%, leave them alone. But for the exam, this is wrong. It's not 100%. It's high, but not 100%. Okay.
Okay. D, most patients presented with a rupture triple A to emergency department survive more than 2 hours, allowing time for a CT scan and assessment for endovascular repair. Yes, I think so.
Yeah, this is very important. And this changed a lot of our teaching. When I was like doing my residency, this was like absolutely wrong because they said patient is a ER, you have to go right away to the we should not do a CAT scan. I should right away to go to the OR. This is all our teaching. But now we have more data showed no. Usually they survive at least 2 hours. So you have the time to do a CAT scan. The reason now, before it used to be contraindicated, now it's like must. Even unstable patients do a CAT scan. But in your way to CAT scan, because CAT scan is very quick now. So what you do, if patient even unstable, you get a CAT scan while you're going to the OR, because OR takes sometimes 10, 15 minutes to get ready. By the time you get ready, you get a CAT scan. And why you do that? Because we go back to improved trial showed for rupture aortic aneurysm, endovascular is less mortality than open repair. So CAT scan is very important to decide if it's good candidate for endovascular or not. Okay. My question now, not to you, because maybe to Ahmed. Why should do a CAT scan? Let's do intraoperative angiogram and then we'll decide for endovascular repair. Can we do that instead of CT? So this way we don't waste time. They can do intraoperative angiogram and then decide if to be good candidates for CT or not.
The sizing will not be right. The sizing will not be right.
You can still size it. I mean, why is that right?
Because the patient is under hypovolemic. The dynamics are not right.
But the same with CT scan. You are hypodynamic. CAT scan, the same thing. So you'll be underestimating the size because it's patient hypotensive.
But there is a balloon there.
Where is the balloon? No, when you do a CAT scan, there's no balloon.
I mean endovascular, because you will size it angio with the balloon in.
I let them say without balloon. Patient still say you can do an angiogram without balloon. No, you cannot, because remember, angiogram show you only the true lumen. You don't see outside,
Mm.
right? So
Yeah.
maybe he has a dilated neck with a thrombus. So you see, the problem is angiogram just the interluminal. You don't see outside. So what you think like a nice neck could be a very bad neck. Maybe it's dilated. So you need a CAT scan. Because again, if it's any thrombus calcification, you don't see it on the angiogram. So angiogram is not good. It's good for length, not for diameters. So you cannot do it to assess an EVAR. You also have to do a CAT scan. All right, next one.
There's one
Lead
thing,
time from
Dr. Samer.
So,
Hi, how are you?
yeah, hello, Muhammad. Yeah, hello, sorry, I
Sorry,
didn't
I
know you
was
are
in
here.
and out. But one thing about rupture, these days, it's like Dr. Samer said, is hypertension is very important. But also, what you can do with these patients, a lot of times in our hospital, at least we put a balloon in these patients if they're unstable. If they're stable, you have time because the CT scan takes, it takes very, very little time to do. It's about 2-3 minutes, by the time you get them in and
Yeah,
out. And then in these patients who have blood pressure between 70 and 90, you leave them alone. You don't give them a lot of fluids. You do permissive hypotensive for those patients. But I have seen the balloon, the endovascular balloon that we put in the ER save people's life because they will be like unconscious and then they'll talk to you. So it's very important to have images before you go into the endovascular suite because how long it takes to do a CT scan is 5-10 minutes. How long it
yeah, that's true.
takes to do angio, it's a lot of time, and you may not be
Yeah.
able to do it. So you essentially can potentially kill somebody. So with that.
Now, okay, Muhammad, you are with us. Let me ask you, when you do, because we don't see much rupture here. When you do it in the ER, do you do any imaging to see where level you put it? You just go
Yeah.
blindly? How you
So
decide? Tell us some like tips and tricks.
right. So
I mean,
no,
how you do it?
you're absolutely right. So we we treat rupture like a trauma. They go to special.
Right.
They go to the special room where you have a fluoroscopy capable. You absolutely have to have fluoroscopy. You can't just put a 12 French sheath into the aorta without having fluoroscopy on those patients. And then you have to heparinize them once you put a balloon too. So, but balloon, Dr. Samer, is like the old days, putting a clamp on the patient, so they're unstable,
Yeah.
you put a clamp and they're already fine, So I think that's
When you put the balloon, do you do an angiogram or just go with vertebral landmark and you put it there like L1,
no, we
L2,
just
something
go
like
with the
that?
vertebral landmark, Let's go.
Landmark, yeah.
I do personally, if I have time, we have a portable IVIS machine. I put IVIS in there just to
Oh,
make sure.
good idea.
Yeah, but we sometimes, not every hospital has that. We have that, so we were lucky about, just having a portable IVIS because we do IVC filters with IVIS, and we have a portable one for that reason. So
And how much you inflate? How you decide? You see the balloon change the
so
shape or you go with the volume?
no, you go with the volume, with the shape, not volume. So you go with the shape.
The
Then
shape,
once
as
you
I'm
have the
saying, the shape.
square,
When it
yeah.
become like
And
flat,
also,
then you see.
yeah, and the way you do it, you absolutely have to have a long sheath. You have a long 45 cm 12 French sheath, or more, so
Mhm.
that's very important. So you have to have a stiff wire. You have, you access with a lot of times the ER they do A-line immediately on these patients. So you have to have a stiff wire. You have to have 12 French sheath. You hug you hug the balloon to the sheath because it won't move, and then we go by the shape, and hemodynamically also. So they become very stable immediately once you do that. They just immediately they have blood pressure. If they're unconscious, most of them even will talk to you. So
Now
it's
the question, Muhammad, if you do this way and then you do CAT scan, you can still see contrast in then there's no contrast
no.
distance. So how
Well,
you
you
can
let
see
it go.
the
You let go in the CAT scan, But these people.
okay.
But I personally, I know there are some people do that in my institution. But personally, when I see patient like that, very unstable, and had to put a balloon, I do him open. I just take him and do
Yeah.
open. So
Yeah, I
that's
agree with that. Yeah.
yeah. If you have someone who really like very sick, it's not even a CAT scan. You just do open. You take him to the OR, you do open, and you figure it out. If they have even thoracoabdominal, you still can sew a graft to that. And save their life. In the meantime.
Yeah.
So
Yeah.
if you can, obviously, like one of the fellows said, it's mortality 50%. is 50% for those patients who come to the hospital, probably, you know, in non-aortic center. It's very high mortality with this. So.
Yeah, it's more than 70-80%. What about this C? Do you do it in a state patient more above 80 and contain rupture? Do you still
About
do him, or
which
you say no? C,
you
age more
see?
than 80 years old with uncontained rupture of thoracic aneurysm.
Well, I
You say
actually
no.
we
You say
have
it
done.
doesn't worse it.
I've done, depends on the C. There are, you know, there's definitely even like if you look at Safi's, he has a paper on you know, operating thoracoabdominal octogenarian. So the outcome is worse, but some of these people do very well, you know. So, but if someone, you know, you don't do anything, has rupture aneurysm, and you let them go, you know, they're gonna die anyway. So obviously, you know, if this patient 80 and he's on dialysis, sick patient, doesn't walk, bedridden, then it's not a bad way to die, you know. But if somebody has a life expectancy of 2 or 3, 4 years, I think it's worth a shot, you know. And a lot of them do well, you know, once they're out of the acute period. They'll be in the hospital for a while, but they'll do well.
Yeah, I agree. All right, thank you, Muhammad. Okay, let's continue now. We go back to you, Ahmed.
Okay. A 69-year-old man with history of hypertension, hyperlipidemia, and 50-pack-year history of smoking undergoes percutaneous endovascular repair of 5.9. Infrarenal fusiform abdominal aortic aneurysm with a standard modular bifurcated graft with distal seal at the distal common iliac arteries bilaterally. He tolerates the procedure well and is discharged on postoperative day 1. Which statement is true regarding the need for vigilant postoperative radiographic surveillance?
Okay.
Okay.
All right. So they talk about surveillance. What we need to do. It's just a regular EVAR, standard EVAR, and they want what you know. Okay.
Okay.
So let's play one by one.
A. Stratification of patient to low and high risk for needing secondary intervention, which determines the follow-up protocol.
Do we have this stratification? Do we have, like you say, like low risk and high risk for?
We don't have that. Either there is endoleak or not.
Yeah, that's right. So we don't have this one. They tried some trial to get to these things, but none of them was really successful, you know. So we don't have this stratification to low and high risk for secondary intervention. Okay, next one.
The duplex ultrasound is equivalent to CT angiography and endoleak detection rate. That's not, is operator dependent, and it's not true. C, late ruptures can be prevented by vigilant postoperative radiographic surveillance. I don't think that is right, because some they ruptured without endoleaks, without evidence of endoleak and CT.
That's true. Because they may have what? Why? How is the rupture without type 1 endoleak?
Maybe endotension. Maybe just there is an endoleak.
What is endotension? Yeah, usually is intermittent type 1A endoleak. Okay, this is what usually it is. And one way to discover it, you know how you discover that?
I theoretically speaking, if we scan them in a prone position, we might detect some of those type 1s.
Yeah, that's true. This is one of the way, correct. But the other way, no, that's true. That's true. And the other way to do a contrast, dynamic contrast duplex ultrasound. Because duplex ultrasound, you can see like see, CAT scan is just rigid, you know, one stage. Duplex ultrasound, you can see it live, you know. So when you give a contrast, so contrast enhance duplex ultrasound, and you follow and you look at the aneurysm, and you can see any blood going to the aneurysm or not, you know. And this is the reason why these days we consider stable sac is a bad sign, because stable sac, it may mean even without endoleak, it may hide type 1 endoleak, and this may rupture. The reason why now is a trend in the future that you need to see the sac regress. So if you see the sac stable, it's not like a bad sign, but it's not a good sign. You have to worry a little bit. Okay. See why it's not shrinking. Okay. Next.
D, if no endoleak or sac enlargement is found in CT angiogram at 1 month, Imaging does not need to be repeated for 12 months with either CT angiography or duplex ultrasound. No, we still will do it at 1 year.
No, but I'm saying is that we need to do it earlier. They said image does not need to be repeated for 12 months. Like if the CAT scan is after 1 month is negative, it's no endoleak. Do you have to be after 6 months or you can wait 1 year?
Wait for 1 year. And unless type 2, 6 months.
Said no endoleak.
No endoleak,
Usually
خلاص
now
1
what
year.
we do now we do 1 month, 6 months, 1 year, and then 1 year
Yes.
after, correct?
Yes.
But this one tell you no, tell you 1 month, 1 year, it's no 6 months. So this is
It's
correct
not
or
the
wrong?
typical we use practically, but
Correct.
in
So this is
written
a good
text,
indication. No,
yeah.
this is good because this is a new SVS guideline. They found that 6 months is useless. So we have to change our practice. You see, I still do 6 months, but I'm going to change it. Because the new SVS guideline, they said, if it's no endoleak after 1 month, you don't have to do 6 months. You can go all the way to 1 year.
Right.
So this is a new information, which is important, you know.
And that's what we
All
do
right.
here in our hospital also. We do one,
You go 1 year?
we do 1 year for abdominal. For thoracic, we still get 1 month, 6 months, but for abdominal, we do
Yeah.
1.
Yeah. Now I still do 6 months, but I'm going to change that because after this one, it's very,
Yeah, I
very
mean,
good
if
to
it's,
know that. Yeah. No endoleak, no need for 6 months.
and
right?
also like anything else, if you have a risky aneurysm, if you did an old man, you know, with a tortuous aneurysm, large neck, had to do aptis, has to do this and that, you can
Yes,
follow
it's
that a little
different.
bit more closely, you know. So, but if straightforward, you just that's what you do. You follow in 1 year, you know.
That's
So
true. That's true. Okay, last one, Ahmed.
MRI has been found to be inferior to CT angiography in detecting endoleaks after endovascular aneurysm repair. It is more sensitive to detect
Yes,
endoleaks.
but we don't do it because it's more, it takes more time consuming and everything. But really,
right.
it's more because it's more dynamic, you know.
And more difficult to read.
Yeah, yes. All right, so this is an easy question. They give a difficult question to Yahya. Yahya, go ahead.
Okay, Dr. Samer.
ولا براء دور مين؟ براء ولا
6
يحيى؟
لا أنا يحيى.
طيب يلا take it.
6 hours following endovascular repair of a 7.5 centimeter abdominal aortic aneurysm in a 68 years old man who is present with hemodynamic instability and is currently intubated and sedated in ICU. You are alerted to the fact that the patient has a distended abdomen that does not improve with NGT placement. In addition, urine output decreased from 20 cc to 10 cc to 5 cc in the past 3 hours. There was successful exclusion of aneurysm below the renal artery without evidence of endoleak on completion angiogram, which the following is true regarding this clinical condition. In this case,
What is clinical condition?
clinical condition compartment syndrome.
Correct. How we diagnose it?
Patient came decreased urine output
Okay.
with a
But how
huge
we measures? How we measures the pressure?
abdominal pressure.
Right. So what then? What's the number we trigger our? We have to do something. This is an important in the exam. What the pressure more than what? 20, 30, 40, 20. Yes, that's very important. This is very hard. Very, I'm sure get this in the exam. Comparison syndrome is very important, like the legs. So any pressure more than 20, it has to be treated by surgery. And how you measure the pressure? Through the Foley catheters, right? This is how we
Yes.
measure the pressure. But the pressure alone is not enough. You have to have a distended abdomen, decrease urine output. What else? You have to have some symptoms. Like if you just measure the pressure and patient has normal urine output, normal cardiac output, normal MRE, you leave it alone. You're not going to treat, pressure. But when you see a sign of decreased perfusion, like again, decreased urine output, decreased cardiac output, decreased like pulmonary, function test, then all tell you that you have to treat it. Okay.
Okay.
So which following statement is true regarding this clinical condition, which is compartment syndrome?
A, decreased tidal volume and increased PCO2 are present.
All right. So when you have a compartment, it's going to compress. You see, you cannot breathe, right? Because the abdomen is very distended and the diaphragm is pushing the diaphragm. So what happens? Tidal volume will go down, and will be containing CO2, will be retaining CO2. So what happened on the ventilator? You see, the tidal volume is going down, and PCO2 will go up. So this is the sign you have a compression of the diaphragm. So this is the sign that this is kind tell you that compartment syndrome is symptomatic. As we said, pulmonary symptoms, cardiac symptom, decrease of cardiac output, and urinary symptoms. So 3 symptoms. Any of them present, then you have to treat it surgically. All right.
Okay, Dr. Sam.
Next.
B, if a laparotomy is performed, an important step to release the retroperitoneal hematoma. No.
No, why need it?
No.
I mean, you just need to release the abdomen, right? You just need to open the abdomen.
Decompress
Leave it
abdomen,
open.
no need.
Yeah, don't open to hematoma and get bleeding and the IC and all the things. No, leave it alone. You can just decompress the abdomen and get out of it. Okay, next one.
Instructing the nurse to perform a sedation holiday will aid in the diagnosis and management of this patient. No.
Okay, why wrong? You know what the sedation holiday? What is that? He talked today about it today in our meeting. Remember, he said sedation holiday. Right. So what happened? I mean, the abdomen is already tense, right? So in this situation, you want to do the opposite. You want to relax the abdomen because putting a lot of pressure decreases blood flow to the kidney, to the bowel, to the lungs. So usually you need to give a muscle relaxant, not because if you hold sedation, it's going to wake up and push more in the heart and the muscles. So you don't do sedation holiday because this will make things worse. If you want to do something really, you have to give him muscle relaxant and make him deeper so you can relax the muscle. It's like laparotomy and decrease the pressure. But it's not the best treatment. I mean, you can try that first, but not improve, then you have to open the abdomen. Okay.
Yes.
Next one.
D, medical management usually obviates the need for laparotomy.
No, usually it fails. I mean, you can try one, but most of the time they fail. Most of the time you have to do is a laparotomy. It's like a compartment syndrome in the leg. You can try it, as a muscle relaxant, but most of the times they don't work. You have to do laparotomy, unfortunately. Okay. Last one.
Last one, contained rupture has higher rate of this condition compared with free rupture.
What's different between? See, different with a free rupture and contained rupture, With a free rupture, what happened? You can give more volume, right? Because you lose more blood, correct? So you give more blood, more volume, patient completely unstable. So what you're ending with more fluid, more edema, more swelling in the bowel. So really, it's a free rupture. You have a worse or higher chance of compartment compared with a contained rupture. Contained rupture is less chance of giving fluid and the blood and losing volume. So this is the reason why you see it more with a free rupture than with a contained rupture. Okay. So the right answer will be
A, decreased tidal volume and increased PCO2.
Yeah. Any question?
Dr. Samer,
yes, go ahead.
The risk of compartment syndrome is increased with a high aortic aneurysm, a large aortic aneurysm.
Not really. I don't think it's related to the size of the aortic aneurysms. I don't think so. It's related. It's the volume, So it doesn't matter if it's. You mean rupture or unrupture?
No, without rupture.
All of them you see with a rupture. I mean, rarely you see compartment with unruptures, because the rupture you give a lot of volume, a lot of fluid. This is what happened, and you have third spacing, So all the fluid go to the abdomen, and you have a swelling in the bowel and edema. This all increase the pressures. But the size of aneurysm, to my knowledge, I don't think so. Will increase the risk of compartment. But free rupture is increased compared with the contained.
Thank you, Dr. Samer.
You're welcome. Muhammad, do you have any experience with a compartment? think Muhammad, he left. Maybe he has a case. All right, let's go back to Bara. You want the next one, Bara?
Yes, Dr. Samer.
Go ahead. Here we are. Let's go. You're there, Bara?
83-year-old woman. Yes, I am. Yeah. 83-year-old woman with the known history of 5.3 centimeter abdominal aortic aneurysm. Present to the emergency department with a sudden onset of lower abdominal pain and near syncope while getting up to go to the bathroom. CT is obtained which show ruptured infrarenal AAA. Which of the following statement is true regarding her initial management?
Okay, so just talk about rupture aortic aneurysm. They're all ruptured. Remember, initial, guys, you have, when you came to the question, you have to read it. This is initial management, not the best management. It's not the
Yes.
urgent management. So initial management. So always you have, when you read the question, concentrate on the last sentence, you know, what they want exactly. Okay, let's say what they have options. All right, go ahead.
Initial blood product transfusion should be initiated to keep hemoglobin more than 10 while reading the operating room. No.
Yeah, this is too much. We said to have to be
Yep.
permissive
Permissive hypotension.
hypotension, right? So
Yes.
hemoglobin, I think 8 or 9 is acceptable. You don't have to go really very aggressive with blood transfusion, you know. So you have to keep it down. Okay, next.
B. General anesthesia is preferred and pretends a survival advantage over local regional anesthesia for ruptured endovascular aortic aneurysm repair. No, we prefer local regional if available, if possible.
Okay.
C. When choosing the sheath length for proximal balloon control, a 45 to 55 centimeter sheath or longer is preferred. Yes, that's correct.
Why we need a long sheath?
For the to support the balloon, occluding balloon.
Correct. Good, correct.
D.
Otherwise, it will
Permissive
move down.
hypotension. Yes.
Yeah.
D. Permissive
Okay.
hypotension with the goal systolic blood pressure less than 70 is recommended. You want it between 90 and 100.
No, it's too high. Between 70 and 90. But not less. This is less than 70. Less than 70 is hypotensive, but 70 to 90 is acceptable. 100 is a bit high. You want to perceive hypotensive. So 70, 90 is acceptable. Less than 70 is hypotensive. How do you know if patient hypotensive without looking at the pressure?
Clinically,
What's that?
the consciousness level, the sign of the
Correct.
hypovolemic shock.
Yeah.
It will
So when
be
patient is
cold
conscious,
extremity.
when the
vomiting.
conscious, yeah, when patient is conscious, the pressure is more than 60 or 70 for sure. When we go less than 70, he go unconscious. So you know that. So you don't want to go to less than 70, but 70 to 90 is acceptable. Okay. Next one.
If transfer to higher level of care hospital is being considered, expedient transfer should be prioritized regardless of the ability to have direct communication between the transferring and the accepting physician. It's better to inform the accepting physician to prepare the room, the OR room, to prepare the stent.
Yeah, that's correct. Yeah, I think it's a simple question. Yes, of course, you cannot just transfer without communicating because saving life is time. It's time ticking. So you have to be, by the time they transfer him, they have to be ready. So they can go directly to the OR or CAT scan. They have to have a device ready, OR ready, anesthesia ready. So you cannot just transfer a patient without communicating. He will die on the ER. All right, it's a simple question. Any question?
I should take the next one also.
Next one. Okay, this is easy. Huh? Okay, next one.
This one easier.
All right. Okay, let's go with this one.
A 65-year-old man. Yeah. 65-year-old man with a history of appendectomy present for yearly follow-up imaging for a known small abdominal aortic aneurysm. Following a review the CT image demonstrating its growth to 5.5 centimeter What treatment strategy should be offered?
All right, so he has 5.5 centimeter. And the problem here, I cannot read it here. To me, it looks a nice neck, but otherwise I put here very short. You see that? I cannot read the number, so it's not a very good
Yes.
questions. But exactly like they want to tell you, it's a short neck. Even though it looks to me it's a nice neck, but I don't know. But when they put this 2 line, they want to tell you it's a short neck. It's not a good question, really. You have to tell you what's the neck length. You cannot just give 2 line.
It's a little bit of
just
a
want to
conical
bet.
neck, you know, I think.
Yeah, it's a conical, correct. Yes, it's a conical. No, it's correct. It's a conical.
Yeah, so,
It's a short here and conical here.
yeah.
Right. So, and he's what? His rupture is normal. Let me see. Appendectomy
No.
images. No, just increasing size, not rupture. It's increasing size. So, what option of treatment you have?
You can do open. You can do chimney.
How old
So
is he? How
fenestrated.
old is he? 65, right?
Yeah.
And they didn't tell you anything. Again, in the exam, if they tell you anything, don't presume. He didn't tell you has a high blood pressure. Didn't say it has a like a diabetes. Doesn't have has a cardiomyopathy. So from the question, you have to presume he's a good, healthy guy. Otherwise, they will tell you, correct?
Yes.
So we have 65 years old, healthy, with a short neck, like, juxtarenal aneurysm. What the best treatment?
Open repair.
Yeah, that's it. So what should be offered? Yes, you can do any of them, but usually the best option for him will be open repair, I mean, you can do fever, all the things, but 65 with a good risk factor, I think open repair is the best choice. And it's all simple question today. Any question?
He put in the question open appendectomy in the scenario. Open appendectomy is not is not hostile abdomen.
No,
No, it's not.
no,
But
at all. No.
but
Yeah.
Yes.
but remember, you have to. There's a little bit of adhesions, you know. They're gonna just show it to make it a little bit difficult, but you shouldn't be shy away from adhesion. You know, take them down. You know, so in general, if someone had surgery, you know, remember it's not redoing the aorta; it's redo just taking adhesion down, moving the colon, moving the small bowel. So that's not hard to do.
Hamad,
Yes.
let me ask you, you're here.
Yeah,
Well,
go
like
ahead.
juxtarenal, like this one with a short neck, do you go transperitoneal or retroperitoneal? Or you don't like retroperitoneal? Or what do you, because it's a
Retroperitoneal is
short neck.
better, you know, but
Yeah,
it's always better to do retroperitoneal. There's a little bit more bleeding with it, you know, in terms of, you know, heparin and post-op, but retroperitoneal, you have full control to fix the whole thing, you know, always. So
you can go higher. Yeah, you can go higher
can go
and
higher, yeah.
easily, especially
But
with a
it
short
depends on,
juxtarenal.
yeah, depends on the expertise also. So there are people trained only transperitoneal. I have one partner who does go the celiac transperitoneal, you know. There are people do retroperitoneal, so retroperitoneal in general is better. It's
Right,
better.
but you said very important. What you feel you are best with it. If you just train intraperitoneal, go intraperitoneal. It's not the time to play with retroperitoneal, especially in emergency or something like that.
Although in this case, in this particular case, you see the right iliac is very calcified. That would make me go transperitoneal on this patient, just because I don't know how easy it's going to be to deal with that. Sometimes
Right.
right iliac is very tricky. Do I need to do a euro by iliac or something like that? I don't know, you know.
That's true.
That's the
That's
only
true.
thing about this one, you know. So,
But what I'm trying to say that you choose between retroperitoneal or intraperitoneal only if you know how to do them both. You just do one to know to do it, keep doing it. It's not a major difference really.
yeah.
But if you have a choice to do them both, then yes. Some cases better to do retroperitoneal, and some cases it's easier to do it intraperitoneal. All right. So again, simple question. Let's go to
Right.
this one.
Yes.
Mias.
That's
Who's
the
Abdullah? Who want?
Arabic
Yes,
song.
dissection. Yeah, Abdullah, want to
A
take this one?
53-year-old
The
man.
dissection.
Yeah. A 33-year-old man presents to the emergency department with chest and back pain. His blood pressure 220/100, and on exam he has a non-palpable right femoral pulse. CT imaging is shown. The initial management strategy including which of the following options? Okay. So he has
All right.
malperfusion to right femoral.
So he has malperfusion to the right femoral. That is a CAT scan. What else you see in CAT scan? Look at the lower part. What do you see? Where's the kidney? Look at the kidney. Look at the left kidney.
Yeah.
What do you see in left kidney? It's no flow, right?
No flow. Yeah, there is no flow.
So you have a complicated type B dissection. There's no flow to
Yes.
the right kidney and no flow to the right femoral, right? Let me see.
Femoral. Yes.
Femoral. So you have an indication to repair. So what do you do with these cases?
TVAR started.
Start with a TVAR, and then, as I said, this is the first step. You do an angiogram.
Then
If it's
do
not
angiogram.
open, then still you have not flow, the collapsed trulumen. So what you use then? We talked about
Let's
last
start
time.
with
Then you
TVAR.
use,
Yes.
sorry?
Start with TVAR. There is then angiogram. There is improve. That's it. Not improve. We need to deal with that.
What options we have? We have a lot of
We have
options, you know, if it's, yeah, go ahead.
we are talking about renal or lower than first picture.
No, I mean, you want to get the renal, right, open and left common femoral. So you do a TVAR and trulumen still not opening enough. Usually, suppose after you do a TVAR, the trulumen will open, everything will open. But let's say for some reason after doing a TVAR, still the trulumen is not open. So you need to open the trulumen. So what do you do? What kind of stent you use? For dissecting stent, right? The Ancover from Cook. You do that to expand the trulumen to see if it can float back to the iliac and to the renal. If you do that, still no flow to the renal or to the iliac, what you do next? Then you go stenting. Okay.
Right.
You try to stent it to get flow to them. You know, some people only do like, you know, septectomy or whatever. But this is usually the steps. I'll ask Muhammad after this question. Well, let's see what options they give us. What options they said?
A. Open repair. B. Left renal and iliac stent. C. Impulse control with IV beta blocker. No. D. Cross femoral bypass. D. E also. There is no E.
This is a next step question though. So
Impulse
but
control
this-
with IV beta blocker.
Yes.
Yes, but this is a bad question. I think it's a bad question.
It's a bad
Because,
questions,
you
yeah.
know, it's a bad
But for the
question. It should
test,
be a TVAR.
yeah,
But for
TVAR,
the test,
especially in the United States, they have this thing now in these tests, like next step, you know, they tell you like somebody had gallbladder disease, what's the next step? You have to say ultrasound, you know, they have this, you know, and the same thing here, I
yeah.
think.
Yeah, but this is tricky. It's not correct because it's not right. I'm not going to put a stent. I'm going to do a TVAR. So a TVAR with none of these options. Yes, you
Yeah,
do control an IV beta blocker, but it's not the main treatment. This is, of course, this is like default.
right.
The main
This is,
treatment,
I
you
mean,
need to open the trulumen. Yeah.
you nailed it. You nailed it. How to approach these patients at very, you know, very contemporary treatment, like Dr. Samer said. You know,
Yeah.
you have malperfusion. You know, so immediately you do TVAR. That's you control hypertension on the way, whatever. But you do TVAR. In this case, I want to just highlight something. So if you look at every dissection, especially with malfusion, you have to identify what is the entry tier that you need to close. Okay, so here there's a major entry tier, looks like, by the subclavian artery, and in this case, if it's emergency and you have, you know, critical limb, critical kidney, do you do carotid subclavian bypass right away? You probably don't, you know, need to. That's one of the indication to cover the carotid subclavian bypass if you have a dominant right vertebral. Or you can use, you know, in the US we have TBE devices, which is, you know, subclavian branch, you can use it. And that's probably what I would do for this case. But then, like Dr. Samer said, you do dissection stent. Dissection stent is a free cell stent that you can still stent through it, and that would open true lumen. And that, most of the cases, they go okay. And then the second highlight I have, so the left, is the left common femoral out on this patient, or which one? Both of them or one?
Is that the right common
Right.
femoral, the right,
So
the
you have to
iliac,
cut
right?
down on that one. So
The
you
right
have to
femoral,
cut
no
down-
right femoral. Yeah.
So in these cases, I think also one of the things you have to cut down on that on the right as well, and be ready to do fem if you need to. You know, sometimes it doesn't open up, or you have to cut down there, do thrombectomy, stent the iliac, maybe. You know, it's a very complicated situation. You know, but you have to address it. You know, by putting a stent first, dissection stent, and then you treat PRN, whatever needs to be treated, you do it. But you have to be ready to do a fem on this patient for sure, if you need to.
That's true. That's true. You see, guys, with the dissection, it's completely unpredictable. So you don't know. After you put a TIVA, you don't know how it's going to dissection behave. So no way you can predict it. So you have to be ready for next steps. So you know way you can tell ahead of time, okay, if I put a TIVA, this will solve my issue. No way. Everyone is different dissection, different entry site. So you have to be ready and do completion angiogram and then decide what next step. The other things, if this patient like in rural area and has to be transferred to another hospital, it takes, especially in Saudi, it takes like, 7, 8, 10 hours to get the patient to where they can do a TVAR, then it's not a bad idea to do a FEM before you transfer him. Do quick FEM and transfer him. At least you can save the legs. The kidney maybe will be gone, but at least you can save the legs. Because if you transfer him, and it's going to take 10, 15 hours, or one day to get him transferred to the area where they can do a TVAR, then by that time, the kidney and the leg will be gone. So just, word of caution. It's different from the state. State, they transfer very quick, but here in Saudi, it takes forever. All right, let's do last question. I don't keep you guys too long. Let's see here. Who is that? Who wants to take the last question? Should be simple. Ahmed, you want to go and take last question?
Okay, Dr. Samer. A 70-year-old woman with multiple myeloma underwent an eventful elective open abdominal aortic aneurysm reconstruction with a tube graft. She presents to the emergency department 10 days postoperative with abdominal distension and nausea. Duplex in the ED shows diffuse ascites. What is the most effective intervention?
What do you think she has?
This could be because of IMA ligation.
No.
Or
She has an open repair, right? She has open
yeah,
repair.
open. Mm.
And what happens when you do open repair? We see it all the time when you do open repair. We see something like white coming out.
Yeah,
Right?
ascites.
Chylus. Yeah, ascites. Anytime you see ascites after abdominal open repair, you have to think about chylus ascites. The reason why, and you see it very common, especially when you go like suprarenal, like right after dissection, you can see the lymphatic, and you can, cut them, and you can see like white, fluid coming out. So try to ligate them. If you don't do that, you may end with a major ascites, chylus ascites. So this patient typically is, it's, of course, I mean, you have to do a CAT scan, rule out other things. Of course, you have to rule out bowel ischemia and everything. But I'm saying it's the way they presented that she has a chylus ascites. So how we treat it?
MPO, TPN, long chain fatty acids.
Okay, that's called correct. But they said what the most effective. You see, the reason why we go back to the question, you have to read the
Most
question.
effective strategy.
Not what the best, what the most effective. Not what the next treatment, what the next step, but the most effective treatment.
Okay. A, diagnostic paracentesis followed by lymphoscintigraphy with the glue embolization. We rarely do this in the peritoneum, صراحة.
Sorry?
We rarely
No,
do
this
this
work
in
very-
the peritoneum.
No, you don't go from peritoneum, you go from the groin. No, we do it here in the hospital. We did a couple of cases here in King Faisal. You go just, it's very simple. You go there, you inject the contrast through the lymph node in the groin. You see the contrast going, you see where the leak, you go there and you inject it. You go everything from the groin.
Yeah, and that's
And
the
even
treatment. That's the treatment. That's the first line treatment for this condition.
Yeah. You just do diagnostic paracentesis, just want to diagnose it. So you do paracentesis diagnosis, but the best treatment these days is just lymphangiogram and just put a glue and done. The same if you have you do carotid subclavian or thoracic outlet syndrome, you have you see lymphatic leak, for a long time, then you do lymphangiogram and do glue embolization. So the thing now becomes the best treatment really. It's not maybe not the first. You can try, of course, the first, MPO, TBN, antibiotics, but the most effective really is lymphangiograph with embolization. Okay.
Okay.
So next one,
admission-
admission IV.
No need for antibiotics and Kyle.
Okay.
IV albumin infusion and GI rest. This doesn't help really. Parenteral nutrition based on long chain triglycerides
Triglycerides.
composition.
Okay.
But they are asking about the
for-
most effective.
Right. But at limit, yes, you give IV antibiotics. You do GI rest. You don't give IV, you give TBN. And usually with Kylus, you give the medium chain, not the long chain.
Medium chain, yes.
Yeah.
Medium chain, yeah. And some people, they give medication called
Octreotide.
octreotide. Yeah.
Mm.
Yeah, they give. But this is, you can start with this one, but really the most effective is to go just do lymphangiograph and don't waste your time and go with the glue. Okay, that's all. Muhammad, you want to add anything before we leave? What do you think?
No, thank you. No, thank you. Sorry
Thank
for
you
coming
for
down.
staying with us, Muhammad. No, but thank you for joining us. Really, very helpful.
Okay.
Learn from your experience.
Thank you. Thank you.
Thank you,
See you
Muhammad.
again.
Thank you, everyone. See you.
Okay,
Take care.
bye-bye.
Bye-bye.
Bye. Take care.
Bye.